I am Mariko. I am Mariko Ouchi, and I am a senior social protection specialist at the ILO New Delhi office. And I'm very much excited to welcome you all to this interesting webinar. Today's webinar theme is on expanding social health protection coverage to the missing middle populations in India. Is a very interesting proposition at even more interesting times. This webinar is the third webinar of fourth webinar series organized by PH4, providing for health. P4H, providing for health. P4H is a global health network aiming to improve social health protection and strengthen health financing systems to promote universal health coverage in low and middle income countries. Its members include multilateral organizations such as WHO, ILO, World Bank, and others, as well as national governmental and developmental organizations in many countries. As you see, P4H has a well-established digital platform that enables health financing experts to connect, collaborate, and share knowledge on a country's progress towards universal health protection. This webinar is also supported by the other partners such as Access Health International and India Health System Collaborative. Concerning social health protection, ILO promotes expansion of universal social health coverage all over the world. ILO aims to optimize all social health protection functions towards outcomes of financial protection of the largest number of population based on principles of equality, equity, and solidarity. There are instances when these vulnerable objectives have been compromised with a narrow focus on financial sustainability of social health insurance programs. While fully approaching and advancing the pursuit of financial sustainability, the ILO promotes social health protection as an instrument of development policy to support people's well-being and productivity at all times. In this webinar, we are planning to discuss the strategy for expanding coverage, the challenges in implementing them, and suggestions, recommendations for offset of challenges. But the disclosure will be a little different today. Just 3 days ago, the government has hinted at expanding PMJ coverage for the missing middle at a small premium. With that note, let me share the flow of today's discussion with you. We first hear the presentation from Dr. Madan Gopal from NITI Aayog, who will make a presentation on their pathfinding report on health insurance for India missing middle. Then we will invite Mr. Ravichandran, Insurance Commissioner at ESIC, to discuss about the coverage and social protection benefit provided by the scheme. And last, we will invite Professor Ajay Shah to reflect on the macroeconomic impact of this proposition, how PMJ has fared in the last 4 years, and lastly, will people buy into the scheme? What will be the valuable value proposition for the beneficiary? While 3 panelists are making presentations, if you have any questions or comments, please leave them in the chat box. Then we will try to revisit your comments and questions as much as our time allows. So let me invite the first speaker, Dr. Madan Gopal, to present his presentation. Dr. Madan Gopal is currently working as a senior consultant on health with NITI Aayog. the Apex Policy think tank for the government of India. He has more than 28 years of experience working on health system reforms and system strengthening in India. He's one of the leading specialists on health issues in India. He is one of the key team members behind the implementation of RSBY in India and now contributing to Ayushman Bharat PMJ. Dr. Madan Gopal, we welcome you. Please go ahead. Thank you.
Thank you, Mariko. And good afternoon, everybody. Let me share my screen. I think the screen is visible. Is the screen visible? Am I audible?
Yes, yes.
Okay, that's fine. Thanks for the introduction and the topic. As you know that, as you have mentioned in your opening remarks, that the government is contemplating expanding the coverage of PMJ, which currently at 50 crore, that is 500 million population, to cover the rest of the population. So the journey has not been that smooth as we have been seeing. Now the coverage is expanded to the remaining population, you see the expansion of the insurance coverage in the country as well. So I would be just saying that what was the prelude for that kind of thought process and other things. We have brought out a report on missing middle report recently, and that has stimulated a lot of discussions around that report. And now we are seeing that kind of things which are coming up. So a lot of work is to be done regarding that also, and the work is in progress with that announcement and other things. Now, if you look at the spending, this is just a scenario, what kind of scenario which we used to have. That means India public spending on health is lowest among the G20 countries. More than 2/3 of the healthcare service are being delivered by the side. More than 2/3 of the expenditure happens in the private sector. Now, this kind of scenario is changing. This used to be the scenario. Spending happens in the private sector, and most of the spending happens to the out-of-pocket expenses. We have a high out-of-pocket expenses with fragmented private care providers and insurers. In India, we usually say that 1 billion population pursuing around 1 billion of providers. They are negotiating their health. That kind of scenario is there, highly fragmented. How to consolidate that? That's a challenge, and PNG is an example of consolidating and bringing together all the providers as well. We do have fragments in the insurance sector also. Besides that, another challenge which is there is the changing burden of the disease, changing pattern of the disease. If you look at the population coverage of the insurance schemes in the country, we still have 40% of the population which is still not having any insurance coverage, and we label them as a missing middle. That means the top 15% are being covered by the organized sector, whereas a few of the people, they are having their self-service insurance scheme. The PMJ covers more or less 40%. The remaining 40% we call them missing middle. So there is an opportunity for improving the health risk pooling by increasing the household purchasing power. As I mentioned earlier, that 1.4 billion people, they are negotiating with million providers. How we can increase their household purchasing power so that they can get the best of the services in the limited capacity. In India, we have a predominant commercial health sector, healthcare provision sector. An emerging but rapidly growing commercial health insurance is there. If you look at the way the insurance sector is moving, from 3% penetration, now it is increasing to 5% to 8%. Apart from that, the government of India and all the state governments, they have committed to improve access to the healthcare. You having access to the healthcare, you see that the health infrastructure has expanded. In the form of extension services, each and every village, that is 900,000 villages, they are having a health worker there, providing preventive, promotive, and the other extension services, health education services. Then we are having a network of around 170,000 health centers which slowly would be upgraded as health and wellness center, providing primary care services from there. And we do have community health centers, district. That kind of access has its focus. But if you look at the footfalls, it's only 50% in that network which is there. We do have around 27,000 health institutions. And if you look at the utilization of that health institution, then you will find that there's a skewed distribution. This gives us a unique opportunity as the infrastructure and other things have been focused and expanded. 40% of the population requires some kind of insurance coverage. So we can do a lot of innovation at 40% into either the public network or into the insurance network. With this thing, I would just highlight that point which I have mentioned earlier. That means 38% of the out-of-pocket expenses happens at the household level, and we have to see that how we pool it so that the efficient use can happen. You just can appreciate the highly fragmented set of benefit package dominated by out-of-pocket expenses. This is a picture depicting that. If we can create multiple efficiency and equity challenges, if we can address the multiple efficiency and equity challenges, then we have cracked the issue of covering this missing middle population. These are the challenges in coming to the risk pooling of this. We are having a fragmented risk pooling system, low levels of health insurance. Health expenditures are largely dominated and driven by high and slow to decreasing out-of-pocket expenses. Fragmented landscape of health insurance products, which are focused on short-term inflation coverage for top incomes. Ineffective incentive framework for. Apart from that, now we are witnessing signs of market failure and unfair competition of commercial health insurances. Take the example of RSBY, where the government has underwritten the insurance package or insurance cover or insurance premium of 750 rupees. But what has happened? You have got the insurance companies have quoted as low as 135 rupees for a coverage of 30,000 for a family of 5 for a year. That kind of unfair competition is happening so as to grab the business. The governance of public and social insurance sector, that's one of the areas which we have identified. All the things are coming from the study which we did with the help of Access and Gates Foundation. So these are all there, they are available on the website. The detailed study is available there. So India has low level and very fragmented risk pooling with household. See that how the risk pooling and fragmenting. At one end, you are having the state and the public health financing, other end, the out-of-pocket expenses. You see the contrast, how the out-of-pocket expenses are dominating financing mechanism in overall system. Then the fast-growing commercial health insurance operating under general regulation is dominated by publicly owned insurances. But if you look at the corpus of the public health insurances and the corpus of the private health insurances, the difference is there. It calls for the regulation for the regulatory reforms in this of the regulator as well. Then the severe distortions in the commercial health insurance market as compared to the well-performing international. There has been unsustainable subsidization of the premium, as I mentioned earlier, that how they are been underwriting many of the things to compensate with the other insurance products. As a result, you see that the distortion and unnecessary, unsustainable subsidization of the premium has happened. Apart from this, is compounded with high administrative cost. You see the private insurance companies and the other insurance companies, how much administrative cost they are incurring. And all it is showing an indirect signs of classical market failure in competing for private health insurance. You see, this is compounded by that. This is adverse selection is also there as you are growing the group insurance, other things. That kind of policy is not there. As a result, what happens? That it's very difficult to negotiate with the insurers for getting a proper package of insurance for these people. Then what suggesting for reforms to expand and improve the risk pooling in India is the existing risk pooling arrangements, like in the formal sector, that will be continuing, but we have to expand the risk pooling through piloting inclusion of informal non-poor population in the contributory thing. That's why you have listened to that kind of announcement. Or we can track both of these strategies for addressing this issue. For reaching the missing middle population, why we want to reach them? Because they are not poor. Many are working in the informal sector, but some of them, they work in the formal sector. So formal sector workers who are not insured. They do not rely on free public sector healthcare, and they purchase high. They don't have that capacity. They do have the capacity to pay and purchase the insurance, but they usually land up purchasing high cost healthcare from the private sector and pay from out of pocket. They are probably based, most of them, they are based in the urban areas, and they have the capacity to pay for the premium. They need health insurance, but are not able to pay the high premium. This is compounded with the fact that they are not aware that such kind of insurances are also available. So what and how and what can be done for this? These are the 4 or 5 challenges which we have identified during the course of discussions. That means we require a standardized product. The pricing should be upfront, transparent and clear what it includes, what it doesn't include. The other important problem for having any vanilla or the good product is the distribution challenges. Nobody can ensure a volume of subscription to a particular insurance company. We do have around 30 plus insurance companies in the countries who are providing health insurance. Can we give a volume to that? As the volume increases, the premium reduces. But we can't ensure the volume to any insurance purpose. That's why the distribution challenges are there. Then another thing which has come in, I have also recently experienced that thing. I am enrolled for a group insurance. But as the insurance company, they have switched over to some other company. As a result, the organization, they have to negotiate with the other insurance company. Now the premium, instead of premium has gone 3 times. As I also mature in age, the premium has got 3 times. Most of the insurance companies, they are focusing on the lower age bracket so that the premium and the liabilities are less. So that is an area where needs to be done if we want to really hit this missing middle population. In the standardization, there has to be simple minimal restrictions, simple delivery channels, inclusion of the Rohini algorithms, which Rohini algorithm is the algorithm followed by the insurance companies, and the principles like PMJ, that is pre-authorized packages are there. The pricing should be standard and uniform. They can vary in the line with the population size covered. And that for distribution, we have to focus on awareness, accessibility, and affordability of that product. Then how to address the adverse selection, that is enrolling families in a group, and we have to enroll them for a fixed period. And we can think of allocating 1 or 2 companies in each state also as to create accountability around that. Another thing which has come up during the course of discussion was to have tax incentive and making insurance number mandatory for taking few defined services as tax filing, GST filing, etc. This is all from my side. Thank you very much.
Thank you very much, Dr. Gopal. It was very extremely rich presentation, and then I think myself also, and then the whole audience learned a lot about the current situation and all challenges, you know, like of healthcare system as well as health finance, particularly the health finance in India. And next, now allow me to invite the next presenter, who is Mr. Ravichandran, Insurance Commissioner at the ESIC, to speak about the ESIC benefits and coverage from a different point of view. So Mr. Ravichandran, we welcome you. Please go ahead.
Good afternoon to everybody, and welcome to this video conference. Presentation, please. Next. Next. Actually, this is the preamble of the Employee State Insurance Act. Actually, ESIC is not only providing health insurance, it is actually a package providing a social security benefits, because apart from the medical coverage which we provide to our beneficiaries, we also provide cash benefits as a part of a total package. And the way it works is with like a risk pooling. All the schemes have been formulated in this manner, and the kind of coverage we are extending to and everything, the basis is the risk pooling and utilization as per the need. Next. Employee state insurance legislation was actually started right after the end of the World War II, when industrialization was at its peak. And in India, it started functioning from 1952, where in Delhi and Kanpur it was started. At present, the coverage of factories and establishments, the wage ceiling is over the period of years. In 1948, the wage ceiling of ESI was 100 rupees. Then it shifted to 300, then 500. Over the years, in the last more than 70 years, the wage ceiling has been periodically enhanced. And as of today, what it stands is the coverage is at 25, the wages is 21,000 per month. But at the same time, the wage ceiling has been made as 25,000 for the persons with disability. The word PWD stands for persons with disability. And this enhancement was made from 1/1/2017. And the contribution which we collect from our covered persons is total is 4%, of which employer share is 3.25% and the individual workers share is 0.75%. And this earlier this used to be 6.5%, and which has now been reduced to 4%. And this reduction has come about from 1/7/2019. The major benefits which we provide under the ESI scheme is for sickness, maternity, disablement, death, and as you know, it is for medical benefit. The medical benefit includes primary, secondary, and tertiary care also. For providing these benefits, we have throughout the country. As you know, India is a very large country, and we are spread across the whole country. As on today, except for the Lakshadweep Islands, the remaining whole country is covered under the ESI scheme, right from Kanyakumari to Kashmir and Gujarat to Arunachal Pradesh. Even ESIC has a presence even in Andaman Nicobar Islands. The only area left is Lakshadweep, and very shortly, maybe in this year or in the next year, even the coverage will be complete across the country. For running of this scheme, the ESIC is coordinating with the state governments. We have about 35 state governments and union territories across the country with whom we have a tie-up for extending primary and secondary care benefits. As I have already mentioned, the ESI applies to the whole of India, and over a period of time, different areas are extended, are brought under the coverage of ESI. Earlier, we used to only notify the industrial centers. We used to be called revenue villages. But after 2015, our area of expansion has shifted from revenue villages to the whole districts. Nowadays, the whole districts are notified for coverage under ESI. Till date, ESI has a presence in 595 districts in the country, of which 442 are full district implementation, 153 are partially notified districts, and we have 148 districts where scheme is yet to be extended. But except maybe a few areas, most of them are districts where the industry availability is very low. most of them are agricultural based or plantation based kind of areas where the exposure to industrial workers also is low. But in the coming years, we are going to bring the expansion of ESI scheme across the country, even to these category of workers. So the same data which we had discussed in the previous slide is made in a presentation by way of a pie chart. The same numbers are available here, and our presence is not there only in 148 districts, which very soon will be spreading across. So what is the coverage benefits available? The ESI Act are exempt from. Once an industry or an establishment comes under the coverage under the ESI Act, automatically that institution gets exempted under the Employees Compensation Act as well as the Maternity Benefit Act. All the benefits provided under this legislation are taken care of by the ESIC. Next. As of today, what it stands is establishments or factories with 10 or more employees are coverable under the ESI Act. We have a certain categories of establishment which are notified. The establishments are like cinema theaters, hotels, transport establishments, and educational institution, medical institution, warehousing organization. There are certain specified notified establishments which are brought under the ESI Act. And irrespective of this factory is a private owned or a government owned, even CPSUs, that is central public sector undertakings, as well as state public sector undertakings, all kind of institutions are coverable under the ESI Act. Next. And as discussed in the previous slide, the coverage is 21,000 for earning member. And for the persons with disability, it is 25,000 per month. And apart from that, there is one more incentive for engaging persons with disability. For the wages up to 25,000 for any unit which engages persons with disability and they are earning wages up to 25,000, Ministry of Social Welfare, Government of India is for a period of 3 years, it is bearing the contribution. The whole contribution of the employer is borne by the Government of India, so that this policy has been brought by Government of India just to encourage employers to give employment to more persons with disability. And for the purpose of this discussion of this presentation, I have given a mention in the bottom of this slide. We'll be using and discussing the words called lakhs and crores. For persons from international institutions, they may not be familiar with this terminology. So I've given this clarification. 10 lakhs is 1 million and 1 crore is 10 million. So you can just make your calculation on the basis of this ratio. So these are the major benefits which are providing is listed out here. Yes, under the ESI Act, we provide medical benefits. And not only during service, even after retirement also, on superannuation, medical benefit is extended to the industrial workers on the basis of some limited subscription. That limited subscription is also provided, which is a very meager amount, a kind of 10 rupees in the Indian currency, which is almost, if you see the annual subscription of 120 rupees will be about $1.50 in the American dollar calculation. Similarly, we provide sickness benefit, temporary disablement benefit, permanent disablement benefit, dependence benefit, maternity. Then there are two kinds of unemployment allowances. One is RGSKY, another is Atal Bimit Kalyan. These are two kinds of unemployment allowances and benefits being provided. And recently, in the last 2 years, due to the spread of COVID-19, a new scheme has also been brought where a COVID-19 relief scheme is also provided for any wage earner who dies due to COVID. His family will be eligible to get a lifelong dependence benefit. And then there is a funeral expenses, which is a one-time payment of rupees 15,000. So if you can see in the scheme, right from the birth of a person to the funeral expenses, there are varieties of benefits which are spread across under the ESI Act. And these are all the certain data which we are providing, where we talk about what is the eligibility criteria for a person to get sickness. This title comes under the sickness benefit. What is the criteria, minimum number of working days for which a person has to have worked, and what will be the maximum number of days for which a person is entitled to avail cash benefits, and what will be the ratio for a person of his salary. For example, in this sickness benefit, a person should have worked for 78 days and contributed for 78 days in a 6 months period, and the same person will be eligible for 91 days in 2 consecutive, that is in a period of 6 months, they will be eligible to obtain 91 days cash benefits. And what would be the cash benefit? It would be at the 70% of the average daily wage. And you can see at the bottom, there is a table which defines how many number of cases have been dealt with by ESIC, and what is the value of amount which has been paid to various workers across the country. For example, in this, the number of cases running at 6.6 lakhs, and in 2018-19, and in 1920 it was 6 lakhs 7,000, and in 2021 you can see that there is a 50% fall in availing of sickness benefit. That is due to the year 2021 was a period of COVID, when throughout the country the industries were shut down, so there was no employment, so majority of people were not eligible to avail sickness benefit because there was no loss of earning capacity. So in lieu of which we had substituted by providing a separate COVID relief also. And so that is why there has been a fall. And as you can see in the current year 21-22, in the subsequent year, as the industry started opening up and as people started getting employment, again there is a rise in the sickness benefit and the amount of outgo also. And this is another benefit, which is extended sickness benefit. Extended sickness benefit is for identified 34 diseases, which are serious kinds of diseases. A few are malignant and disorders, and like tuberculosis, leprosy. These are the kind of benefits which are provided. Being a serious kind of disease, the rates are also higher. In the earlier one, it was 70%. Now it is 80% in this extended sickness benefit. And the data at the bottom also provides the kind of quantum which has been availed during the last few years. Next. Now, this is the maternity benefit. In the ESI scheme, maternity benefit is extended up to 26 weeks confinement. This maternity benefit is provided. 100% of wages is extended to the insured woman, and till 2017, ESIC was only paying up for 12 weeks. As per international standards, we have increased it to 26 weeks. And so an insured woman under the ESI scheme gets full 100% wages for 6 months. And not only for that, she also gets for miscarriage as well as for sickness which is arising out of confinement. And these are some data. As you can see, that number of cases is almost kind of static. It is hovering around 40,000. So the maternity rates are stabilizing in the country. Next. And this category of disablement is divided into two. One is the disablement benefit, which is given at the top, temporary disablement, and the one at the bottom is called permanent disablement. Any worker sustaining an employment injury, they are eligible for getting this benefits. The temporary disablement benefit is up to till the person gets cured. The person is eligible for the temporary disablement, and the permanent disablement is for permanent loss of earning capacity. This permanent disablement is paid till life of the individual, it is paid. And similarly, if the disablement leads to a death of an individual, the family gets entitled to the dependent benefit. either the widow or a widowed mother or the spouse it also gets it. Dependent children get it up to the age of 25. The minimum dependent benefit fixed is 1,200 per month, irrespective, even if for persons if their wages are very low, and even if their rate comes below 1,200, they still will be eligible for the minimum of 1,200 as a pension. Here also it is the dependent benefit is paid lifelong to the family members. Then as discussed earlier, the funeral expenses is also there. These are the certain data which provides the number of cases and amount which has been paid during the last few years as funeral expenses. And this is the Rajiv Gandhi Shramik Kalyan Yojana, is an unemployment allowance. It was introduced in the year 2005. Various industrial workers where the company is shut down or the company goes for a retrenchment, or even if the individual is permanently disablement, if their disability is beyond 40% and they lose a job also, they also get this unemployment allowance. And as you can see, these are the values of outgo which are there in this country against this scheme. A new scheme was introduced in 2018. The earlier unemployment scheme was kind of had a lot of stringent conditionalities. So a new scheme was brought where it's not a kind of a benefit, a temporary relief is provided for a period of 6 months. About 50% of wages is paid for. If it gets extended, another it is reduced and 25% of wages is paid. You can see earlier I had discussed that in sickness benefit there was a drastic fall during the year 2021. The amount of sickness benefit claim was very low. You can see here that in Atal Bimit Kalyan Yojana in the year 2021 there is a steep rise as compared to the previous year, because due to COVID, lot of people were unemployed, and since their factories were not working, they were not eligible for sickness benefit, but they substituted and start getting benefits under this scheme. So that is why your numbers in the year 2021, there were 45,000 cases against which payments have been made here. And this is the new, a small brief on the what exactly is the COVID relief. A person during his whole life's service time for 90 days, they can get a payment, and the family also, in case of a death, they will family will get a dependence benefit equivalent to an employment injury. So these are the number of cases up to March 31st, 3,939 cases, and amount of 47.39 lakhs have been paid as a COVID relief scheme. Apart from that, ESIC provides all the gamut of medical care, right from primary medical care to secondary as well as the tertiary. Even a person after retirement also, on certain conditionalities which have been listed at the bottom, on payment of just $1.5, family, that is a person and the spouse, can get medical care in the ESI system for each year. So for every year they have to renew their subscription and get covered under the medical benefit under this scheme. So for what do we do for providing medical care? Across the country, ESI is having 1,517 dispensaries, of which 1,400 are run by respective state governments, and 36 dispensaries are run by the ESI corporation. And ESIC has also got 76 dispensary cum branch offices. There are more than 1,000 insured medical practitioners who are functioning as a tie-up clinicians, and we have modified employer utilization dispensaries also. For the purpose of secondary care, we have 160 hospitals spread across the country, of which 110 are run by the state governments and 50 are run by the ESIC directly. And to take care of the shortage of doctors, ESIC has started running medical colleges, and in the last 10 years, we have set up 8 medical colleges. and each medical college has got about 125 seats. So you can see almost every year there are about 1,000 medical students who are coming out of ESI medical colleges, and they also, after the completion of the course, they also serve the organization. So ESIC takes care of its shortage of medical manpower by deploying these medical students during their study tenure, and on completion of the 4-year degree, for 1 year they will be serving the organization under a bond period. Apart from that, we have more than 2,000 private hospitals with whom we have tied up, and as discussed earlier, we have a tie up with Ayushman Bharat PMJY also in 157 districts. More than 3,994 private hospitals are extending medical services to ESI beneficiaries through PMJY tie-up. And we have 6 postgraduate medical colleges also, 2 nursing and 2 paramedical colleges. Next. So this is the kind of medical infrastructure which we have across the country. 160 hospital, then dispensaries. We have ISM, which is an Indian system of medicine. We have 312 departments under Indian system of medicine. ESI as a whole has got more than 25,000 hospital beds. And the other data we have already earlier discussed. This is a new thing which had been doing since last 2 years. Initially, we had run a pilot study in 2 districts of the country, and followed by, as of today, we have a tie-up in 157 districts, and 52,000 insured persons are ESI insured persons are tagged in the PMJY scheme, and this scheme is being extended to across the various states. And in the coming years, we expect that this PMJY tie-up will be done across the country in all the districts. And for this purpose, for periodical transaction, ESIC and PMJY are holding an escrow account wherein ESIC transfers money to the escrow account, and on the basis of utilization, PMJY will be drawing funds from that. So there will be a smooth transition of funds, and no services should be held up for want of funds. So a escrow kind of account has been opened wherein we regularly remit money, and the PMJY draws the money continuously from that on the basis of requirement. So this is the overall look where we have been moving on in the over a period of time. In the year 2018 and 19, which is not there, our ESI scheme was available only on 390 districts, and in this period we have spread across 595 districts across the country. Next. As you all know that a new code on social security 2020 has already been passed in the Parliament. A common labor laws have been defined. It is awaiting the notification. Once this code comes into effect, ESI Act will be extended throughout the country. Instead of notifying one by one, the whole country will automatically come under the coverage. All factories and establishments also will become coverable under ESI. Similarly, at present, if you see, the coverage of needs a 10 persons in a factory or an establishment for coverage, but once code on social security comes, for hazardous industry, automatically, even if there is a 1 person, the industry will get automatically covered. Then there is a new provision has been introduced in the code which says that a voluntary coverage for establishment having less than 10 employees, then plantation industry, tea plantation, coffee plantation, all those activities will also get covered under the ESI Act. Similarly, special schemes are being formulated both by the central government as well as the state governments for coverage of gig workers, platform workers, unorganized workers, so that ESI scheme can be spread across all the category of workers. The kind of thing which this whole VC is about to cover the missing middle. Though ESIC has been making its efforts to spread its coverage not only from the bottom level of workers who are earning wages less than 21,000 also, but slowly we are trying to cover all the gamut of industries and activities so that everybody can get the benefit of social security. Thank you.
Thank you very much, Mr. Ravichandran. It was very rich and detailed presentation, and then I'm sure that the audience must have a lot of idea about how ESIC is functioning, and then how ESIC can further contribute to extend the coverage to the missing middle. I will come back to this question a bit later, like after the presentation of Professor Shah. So now let me invite the third presenter, third panelist, Professor Ajay Shah. Professor Ajay Shah, for his reflection on the macro impact of these propositions. Professor Shah studied at IIT Bombay and USC Los Angeles. He has held positions at the Center for Monitoring Indian Economy, Indira Gandhi Institute for Development Research, Department of Economics Affairs at the Ministry of Finance, and National Institute for Public Finance and Policy. He is now part of the ex-Kedia Forum and Jindal Global University. His research is at the intersection of economics, law, and public administration. Professor Shah, we welcome you. Please go ahead.
Thank you. I want to talk about three things. The first is the question of the fiscal consequences of these programs like PMJAY. There is a literature that developed originally around the government-funded health insurance schemes at the level of subnational governments, and many of those ideas and lessons carry forward to the PMJAY as well. What it boils down to is that if we do a careful costing of the benefits, and if we multiply through with a significant level of utilization, then it comes to very, very large numbers. Certainly much larger numbers than those that are at present being budgeted in the fiscal case, in the fiscal analysis. So I think that we should be thinking more about these problems. In an adjacent area, not health, but pensions, we have seen how right from 1955 onwards, there were many decisions made in India about pensions, which have not worked out very well, where the implicit pension debt that has come to the government has become pretty enormous. So it is better to do thorough calculations and be cautious at every step of the way. And even today, it appears that there is a mismatch between the promises that are being made in terms of the way packages are being put together versus the fiscal consequences for the country. Okay, the second thing is about the additional 40 crore people. Now, whenever there is a voluntary scheme, there is a problem with adverse selection, and small premiums don't cover the bias in favor of unhealthy people who will join. And unlike the original poor who are covered in PMJAY, the additional people are more in cities where there is more healthcare facilities. So we run the risk of utilization being high. I'm reminded of what happened in Indonesia. They had a mandated scheme. It was not even voluntary. And the government ended up spending a lot of money when these kinds of programs have been announced. Similarly, you see in China also, where government spending tripled in a few years. So I feel we should think more about how the difference in urban areas where there are constraints in supply, which are different from the rural areas, could generate very different fiscal consequences. Finally, just for a strategic sense about PMJAY and how we might like to analyze this going forward, I think that what we need at the heart of a health system is a very analytical thinking about segmenting different groups of populations, different kinds of providers, and trying to judge the places where a given level of healthcare can be obtained in a minimum cost way. And the moment we take this seriously, it will become inevitable, in my opinion, that this should be a very heterogeneous program across different parts of the country. Health care is a place where there are significant labor costs, and as GDP growth happens, those labor costs will grow dramatically. This is Baumol cost disease, and the mismatch between fiscal capacity and healthcare expenses is a very subtle battle, and one with very different conditions all over the country. So I would much prefer if there were 100 different programs all over the country. So a much more decentralized approach would work better, rather than the attempt at having something uniform that works all over the country, because the sheer heterogeneity of India plays against the accomplishment of a scheme that is at once useful to many people and is fiscally viable. So these are my quick thoughts about what I'm seeing in the big picture today, and I'm happy to stay in the conversation as we go further into this with others in the room.
Thank you very much for your very important, like points to be raised, like for the food for thought for further discussion. I'm from Japan, and then, like my country has a so-called universal healthcare, and then which is very good system, but at the same time that this fiscal problem is very serious, and then it's universal healthcare is a very beautiful thing, but at the same time that is it feasible to run in the long term? Like this is a big question actually, to be realistic. And then I had some operation last year, and then because of the Japanese healthcare system, it didn't cost that much. Like I think I'm paying just 10% or something of the total cost, because of the Japanese system. But I myself, as a Japanese, worry about the Japanese healthcare system in terms of the fiscal side, and then which has been already pointed out by Professor Shah. And then country like India, which is in a economically growing trend, like country, like it's not easy. We need to be carefully design the social security system, including the healthcare system or health insurance system, because as Professor mentioned, that the labor cost is going high, and the healthcare labor cost, health related personnel labor cost is going high, supposed to be going high. If it's not going high, then country may eventually lose these healthcare workers, which is also happening in some other countries, because they are skilled workers, and then they may move to some other countries where they can earn much better than their origin country. So there are many issues, like which is in relation to the fiscal discussion on the healthcare issues or health insurance issues. There are many impact, macroeconomics or the labor market impact to be taken into consideration. So I think, thank you very much. Just I wanted to make some comments, like to the professor's presentation. And I think it's time to go for the all kind of open session to the answering to the questions which has been already raised in the Q&A box and chat box. Unfortunately, it's very unfortunate to mention, but Dr. Gopal has been, Madan Gopal has some urgent commitment prior to this workshop, and then he had to leave this session already. So, like in this sense that Unfortunately, he is not available at this moment, but some of the questions which is related to the presentation of the Professor Shah and then also Mr. Ravichandran, I think we would try to pick up this particularly for some of the comments and questions which is relevant to their presentations. And then maybe we can extend our discussion further. So I think there are some questions particularly to the ESIC, like I think some of them are, like more of the functional issues of ESIC. So let me pick up one of the questions, just a moment, from the ESIC. If there's some questions are asking some numbers, and then if the answer can be provided immediately, I would highly appreciate. But if it's some data or something is not available, then please don't hesitate to answer in this way. So one of the questions is that what is the coverage of ESI as a total population, which is quite
at present,
important, the basic but quite important question.
Actually, ESIC at present is providing benefits to about 13 crore, which is actually 130 million persons, and it is about 10% of the total population of the country. Everybody knows that the population of the country is 1.3 billion. So we are extending, ESI is providing its medical benefits to about 130 million people, which is 10% of the country's population.
10% of the country of the population is answer. Thank you very much. I'm sorry, but there are some ESI, like questions, like listing up in the chat. So I'd like to continue a little bit about this question on the line of ESI Act or ESIC. So the second question coming is, which are the factories and establishments that fall under the ESI Act? What are the criteria? I think it has been already covered in the presentation, but it's very kind to repeat this answer.
No, it's a simple answer. All factories or establishments having 10 or more persons working automatically gets covered under irrespective of what kind of manufacturing activity it does. It is irrelevant. It should be manufacturing something and it should have 10 persons. So it becomes covered under the ESI Act.
Thank you very much. Next question, which is also ESI issue. I'm sorry to ask again and again, but what was the main reason to reduce the contribution level from 5% to 4% in the ESI? Was it politically motivated?
No, actually, even the kind of benefits which we are going to spread across and our fund position were quite sufficient, and there is a provision in the ESI Act which says that as and when the funds of the organization are sufficient enough, it is for the organization to decide what kind of benefit it can extend, what kind of contribution it will levy. So the present our funding position made us reduce the liability on both the employers as well as the employees.
Okay, thank you very much. Maybe next question I'd like to ask to Professor Shah. There are some questions about the insurance issues. So the first question is about the insurance companies do not have health insurance policy for senior citizens. Insurance is most needed for the elderly who are without income and have various health problems. There is a policy where private insurance companies should include senior citizens. How do you think about this question? It's very kind to provide your comments.
It's a difficult problem. As we know well, the healthcare expenses of older people goes up dramatically. And there are other countries where we see phenomena like half of the lifetime healthcare expenses are incurred in the last 1 year of life. So we have to tread carefully in these things, build up experience, and figure out how best to design programs. So while you may feel it is morally desirable, it also has to make business sense, and that is the only way in which we can make progress.
Yes, absolutely. And then, in my country also, that there are many private providers, private insurance companies providing the health insurance or health insurance, some sorts of health insurance to the seniors, but senior citizens, but the premium is very high because the risk factor is high. So, there are systems, but in the end, if it's a private insurance, then it's, as the professor mentioned, that it's a business. So the premium becomes automatically high. So, it's not impossible at all, but they just have to meet this business line as well as the actual expenditure and the risks of the health risks of the seniors. And the next question is also related to the insurance, and then I'd like to continue with Professor. Actually, this was the question to Dr. Madan Gopal, but I think it would be good to be answered by Professor Shah also. There is a high cost on risk pooling and a way to increase risk pooling. Do you think there is any merit for focusing on introducing strict regulations for providers and insurers? There are pros and cons, no?
Yeah. So when you say strict regulation, do you mean strict regulations that create more risk pooling? Well, I mean, the ultimate kind of state coercion is mandatory, where people are forced to go into a healthcare system. It's less exciting than meets the eye. It depends on how much you want to socialize these things. There is a correct zone of risk pooling where plausibly homogeneous people feel comfortable being in a pool. So, occupational risk pooling works rather well. Once you start ratcheting up the state coercion, the social acceptance of a program goes down, and really mixing highly heterogeneous people into single risk pools doesn't work so well. And that was my original point, that India is so highly heterogeneous. Whether you think in terms of geographical location, or you think in terms of the actual health of the people, if you think in terms of healthcare expenses, you think in terms of income, India is highly heterogeneous. So, any single national thing is going to work badly. There'll be a large number of unhappy people in any large scale forcible pooling. So think very carefully about the word coercion. Where will you coerce people? And, are you really sure you want to force people to do something or the other? And how much of a social and political backlash will be there? Do you believe that the political bureaucratic system will devise wise, proportionate, and appropriate pathways of coercion? I feel we should walk softly whenever you start forcing people.
Thank you very much for a very good answer. I liked your wording of the correct zone of risk pooling. This is exactly the issue to be explained for this question, as I understand, because I fully agree that the government needs to provide certain regulations for any of the social security package. It doesn't matter either private or public or etc. Even for the private system, still it requires certain regulations to be there. But what is a correct zone, of risk pooling, as a professor mentioned, it depends on the country, and it depends on the country's insurance regulation per se, or financial market regulation, financial market development, or so many other factors needs to be taken into account. And then India is such a large country and then highly heterogeneous, as professor mentioned, and then it's very difficult to provide something one uniform. There is a minimum regulation to be set, just as it's like a minimum wage, it's same. Minimum can be set, but it requires some customization depending on the situation, depending on the states, depending on the groups, depending on. So in this sense that I think, I personally think that a certain regulation would be needed, yes, but how much depends on how the people think, how the market reacts, how the private sector can make business, etc., etc. So next question is about the ESIC. So I go back to Mr. Ravichandran. What would you say is the reason for ESIC's poor claim ratio? Tough question. It has ranged from 40 to 50% over the past 10 years. So do you have any comments for this question?
Just can you repeat the question? What is the reason for increase in?
What is the reason for poor claim ratio? It has ranged from 40 to 50% over the past 10 years. So the claim ratio seems a bit lower than expectation. So what exactly are the reasons?
Actually, right. ESIC provides cash benefits only in case. It's not that if a person falls sick, automatically they get cash benefit. The person should fall sick, and due to his sickness, the person should need to go on a leave due to sickness. So there is a certification process. So unless there is a need for the individual to not to go for employment during that sickness, only then we compensate for the loss of wages. It's not automatically for any sickness they get maybe some, and we have kept the ratio of eligibility for wages also at 70% and 80%, and only in serious diseases it goes up to 90%. Under normal circumstances, it is only about 70 to 80%. For small, not normal day-to-day sickness, people don't avail leave under ESI. They prefer rather to go for employment, and only in serious needs they go for ESI leave. That is the reason. So actually, when the leave ratio is less, your productivity is actually more. We see it from that perspective.
Thank you very much. I think next question I'd like to ask to both of them. Health insurance companies, I think here it means private health insurance company, as I understand. Health insurance companies should be permitted to offer sickness benefit, currently not permitted except for accidental disability. So how do you, what's your opinion about this question in the comments? Please start with Mr. Ravichandran and then the professor.
Actually, under ESA, we are providing sickness benefit. So it is not, and our ratio, if you can see, is quite high. The eligibility, as I had shown in my presentation, during a period of 1 year, a person is eligible to avail 91 days, which is equivalent to about 3 months of his wages. So a person in a year can avail 3 months sickness benefit, and we are actually providing. So I may not be the appropriate authority to say whether sickness benefit should be provided. Moreover, the organization ESIC is a statutory kind of organization. So whatever benefits we provide, it is as per the legislation, and there's no question of whether to provide or not to provide. And this is as per the ILO conventions or the kind of benefits which we are providing. So I may not be the right authority to comment on that.
Okay, thank you very much. And how about Professor? I think this question is more for the private sector. You know, private health insurance companies are not permitted to provide sickness benefits. So how do you consider about the involvement of the private health insurers in the field of the sickness benefit?
Generally, I'm always in favor of more economic freedom, which is a good thing if private firms will talk to customers and think of what would be the most useful to them. But alongside this, I also think that it's better both for the provider and the customer to have a focused clarity that health is one puzzle, and you focus and you solve that puzzle and build good health insurance products that are useful for that one puzzle. I personally feel it's better to have precision of objective and specialization.
Thank you very much. Then the next question is to Mr. Ravichandran. like it's going back to the issue, the point of our discussion first, most important point of our discussion about the extension of the coverage to the missing middle. Both PMJ and ESIC are social health insurance schemes. If ESIC were invited to cover the missing middle, what would have been your strategy to extend coverage? So first start with Mr. Ravichandran. I think this is a very important question.
No, right. Actually, as I had told earlier, we have been periodically increasing our wage ceiling also for the purpose of coverage. Earlier it was 10,000, then we had enhanced it to 15,000. Now we are standing at 21,000. And as time goes by, I think once this Code of Social Security comes, where a provision has been made that even if a person goes beyond wages goes beyond 21,000, with restricting the contribution as well as benefits to 21,000, the person will still remain under coverage even if their salary goes up. This kind of voluntary clauses have been brought under the Code on Social Security, and it will be open for the individual to decide whether they want to continue under the Social Security of ESI or not. This is one aspect. Another aspect is, as I had again made on the presentation, we have been spreading our wings also. Our area of coverage was spread across only about 390 districts out of the 740 districts of the country. Slowly, another 200 districts we have added under coverage. And by the end of this year or by next year, we are hoping that the whole country is going to come under the ambit of ESI coverage. So our intention is to expand the social coverage to as many persons as possible. For example, this voluntary coverage of units less than 10 employees is also being thought of. And similarly, coverage of plantation workers who are at present, it's not that plantation is not covered under the Social Security. There is a separate Plantation Social Security Act available under the in the country. But despite that, the infrastructure available under those institutions are quite low. So they feel that ESIC can serve them better in the aspect of Medicare. So that is why a lot of demand has come that ESIC should extend its benefits to the plantation workers also. And we are also open in future that we will be covering those kind of institutions. So slowly we are kind of expanding, and we are ready for that expansion. As I had told earlier, we have been starting number of dispensaries also we are spreading. And earlier in the past presentation, I had said that we are having 160 hospitals. And we are actually started planning for building another 54 hospitals also. So in the next 4 to 5 years, we will be having another more than 50 additional hospitals to provide. So ESIC, not only by way of coverage, we are also expanding our infrastructure.
Okay, thank you very much. Maybe I will add one more question, like to this question. You mentioned about the increase of the wage ceiling, like which would give a possibility to expand the coverage of the upper missing middle, I would say. So how about your strategy of covering the lower missing middle apart from this infrastructure issues? The reason why I'm asking is that there are some commitments made under the new Social Security Code, for example, like gig and platform workers, plantation workers, etc., etc. They may possibly be the lower missing middle or middle missing middle, like because due to their type of the job and the income level. So in this sense, that what is the ESIC's kind of idea in terms of covering the kind of the lower missing middle strategy to expand the social insurance or social protection to the lower missing middle?
Rather, I would say our presence is already there. I had seen some when this Code on Social Security was being formulated. they were saying that there will be about 50 lakh new persons who will be categorized as gig and platform workers who will come newly under coverage under ESI. I have a different perception. As you see, I have been working in different states, and many of the states have already been categorizing this gig and platform workers under a different category. What I see is this institutions which are engaging them are today also covering them under ESI in a different kind of, they are covering them as logistics personnel. And when the new category of gig and platform workers is going to come, they will be shifting those logistics persons from that category to this, so that the company's liability towards their overheads, towards the long-term payments like gratuity and pension, those things will come down. For that purpose, they will shift those category of logistics people so we are all under ESI. These people are already covered under different category. So I see a lesser number of coverage under gig and platform, not what is being expected. But this is my personal opinion. Out of my experience and exposure, I am making this assessment. And you were talking about the lower middle class, lower missing middle. Under the ESI, there is also another provision wherein we were talking about the contributions which are applicable to both workers as well as employers. 0.75% of the wages is being paid as the individual's contribution, and 3.25% is paid as the employer's contribution. Within this, we have built a separate provision also, wherein we have kept a different kind of a slab. We have a different slab of daily wages. If a person's daily wages falls below that particular value, the individual need not pay his contribution. So actually, for a lower person earning very low wages, we are giving them a kind of relief for not to pay employees' contribution. Rather, nobody contributes. Even employer doesn't contribute. The person gets all these schemes free of cost. So we are having a protection clause for low paid wages workers also to have a better benefit under the ESI, so that they don't have a loss of wages. Lesser amount of wages is also they don't get. At the same time, they get social security coverage also.
Okay, thank you very much. Next question I'd like to ask the professor, Professor Shah. Healthcare in India is largely unregulated, whereas that health insurance is regulated. Is the current payer-provider ecosystem ideal to achieve universal health coverage?
Universal health coverage is quite a stretch for India. Now, there is a work program on establishing some minimum legal system surrounding the healthcare industry. And I think there's also a very big upside for private health insurance companies to achieve scale and then develop the intelligence of analyzing the work of the healthcare providers and starting to create pressure on the healthcare providers. So these are both important journeys that need to be undertaken.
Okay. Thank you very much. Just a moment. There are some other questions. There is another question with the ESIC. I'm sorry to go back to Mr. Ravichandran. Under ESIC, what is the status of implementation of eSham card for the workers in the unorganized sector? What would be the benefit under eSham card?
At present, ESIC is covering only the organized sector of workers. Only after the Code on Social Security is notified, only after it starts, there will be special schemes. The law provides that a special different kind of scheme, not the whole package, but a special schemes will be provided. The role of ESIC will be only limited to providing medical care to those unorganized and gig and platform workers. There is a list of kind of benefits which are listed under the Code on Social Security, but role of ESIC will be limited to healthcare.
Okay, thank you very much. I think there are some other questions there, but I think it's already kind of time is approaching to close the session. And just a moment. So I'd like to ask the same question actually to the professor, which I asked, like maybe the three questions before, about the very basic question, which is linking to the theme of this panel discussion about both PMJY and the ESIC are the social health insurance schemes. What's your opinion of the strategy to extend the coverage of the missing middle? Like not only like whether to expand furthermore of PMJ, ESIC, somehow more involvement of the private insurers or the combination, or could you share your idea of how to achieve the expansion of the coverage to the missing middle?
There is an interesting foundation inside PMJAY. It needs to turn into a full-fledged health system. And the heart and soul of a healthcare system is data and research. If PMJAY is able to achieve that level of knowledge about individuals, about individual healthcare providers, and is able to create checks and balances, then we are on the way to becoming a good quality payer. Bulk purchaser. That is not there at present. PMJY does not have the internal systems, the procedures, the sophisticated purchasing. PMJY just has ad hoc prices which are being pulled out of the air, and then that doesn't work too well. I think ESI is further away from this process because they come with the legacy of being a large public sector healthcare organization. So I think what is needed is to wind down the healthcare aspects of ESI and turn it into a purchaser where there is an arm's length between the ESI itself, which becomes more of a normal healthcare system, and the work is done by private organizations with once again data and intelligence driving the way. And once you go down this route, you really need to think of 100 different health systems for the geographical health system and income heterogeneity of the country. If we try to push the metaphor of one single national anything, we'll end up doing it badly.
Okay.
Can I just intervene on? I just wanted to ask Professor Shah on this clarification. Earlier in the introduction, Professor Shah had mentioned that there is a there is a urban and rural divide in providing healthcare and utilization also. You were mentioning that even in the insurance, private insurance or private healthcare, the concentration of infrastructure as well as utilization is high in the urban centers, whereas the same is low in the rural centers. Yes. In ESI also, we face a similar kind of a situation. Our target audience is actually industries where more workers are available, and normally industries are concentrated around urban centers. So we have concentrated our infrastructure also around locations depending on the number of persons we have to service. And at the same time, we have a lot of remote locations where industrialization is quite high, but the location can still be termed as rural centers. I can give a few examples like Ankleshwar, Vapi. These are all very rural centers where concentration of industries is high. Industries automatically number of workers is high. So we have to provide our services there. And as you know that when we start extending our infrastructure in those locations, it's very hard to get manpower who will move there. Your healthcare professionals are not easily ready to move to rural centers to provide services. So automatically, so that is why we are trying to build up if you had seen in our presentation, not only we have our own infrastructure of hospitals and dispensaries, we have also made tie-up with more than 1,000 private practitioners for primary care, as well as more than 2,000 private hospitals for providing secondary care. At the same time, as a third level, we are also entering up with PMJY, where about 4,000 hospitals are also come up. Now the question is, if I don't set up an infrastructure in a rural area where I have taken a contribution and committed to provide a service, and there is no private medical care available in the rural center, I have no option but to set up my own infrastructure. Whereas you have been telling that we should.
Mr. Ravichandran, I appreciate your quandary. It is a difficult situation that you are placed in, and it is really difficult to do what you are doing. So I don't mean to denigrate the work at all.
No, nothing, no offense taken. I'm only saying,
So here's my opinion that what we need is a market-based price discovery. So imagine if you were to put out contracts where in Bombay, you want ABCD capabilities. There is a profusion of providers in Bombay, and you would be able to obtain those at reasonably low prices. Whereas in a Mofussil area, you would end up finding a high price for those same things because it is difficult. So if you and I were running a healthcare facility at a remote place, it is difficult for us to find the doctor, to find the nurse, to find the correct materials to go into modern technology inside a hospital. Everything is costly when operating in a remote place. So I want to give an analogy from the field of water. Because of economies of scale, to actually do bulk water provision for a large city is cheaper than doing water for a village. And so our minds have to turn this upside down, that to actually serve rural India, we have to be willing to pay more, not less. And these prices have to be discovered locality by locality, that depending on where you are, achieving a desired objective will end up generating different prices. And then that's the complex relationship with the private sector that we have to develop. And you would then become more of a purchaser, more of a payer. And of course, the second part of your brain is you'll constantly be worrying about fraud, where a private person will claim to do some work and actually do nothing. So being a purchaser, being a payer is very difficult. I don't want to at all imply it is easy, but in my opinion, that's our journey going forward. That's what we have to build up. We have to build up that information, research, and contracting with private persons' DNA inside both ESI and PMJY. Whereas in a way for you from a management point of view, what is familiar, what is comfortable for you is building more of your own owned facilities. And that has its own problems. But I feel that we have to cross that hump. We have to pay the fixed cost where ESI turns itself from the DNA of a healthcare producer to the DNA of a health system, which is a healthcare buyer.
Thank you very much for all comments.
What would be the difference between ESI, which is a social security organization, and a private insurance player who is into health sector?
It's a good question. Potentially, you could get your work done by contracting out to a private health insurance company. That's a fair thought. That is it more efficient to do it under the rubric of Ministry of Labor, or is it better for Ministry? So now you go back to like an RSBY worldview, that are we better off contracting it to a private health insurance company? That's a fair question. I don't have an opinion, but it is something that we should debate.
Thank you very much. I think this this discussion is depends on how people think that, you know, like what is the health insurance or healthcare as a public goods, how much of the market principle to be involved in for this discussion, because of course that there's a size economy of the scale, and that there are more patients available in urban area, then the medical costs might be lower, you know, whereas that in a remote area, that where the people are living in remotely, and then it requires more transport and etc. But that's the reason why there is a risk pooling mechanism to be in place, because people, everybody has a right to access to the decent health care. This is a principle of the universal health care. And then, you know, like if the urban people who is asked to pay a very high premium or the contribution rate, then their access to the healthcare system is very much restricted because of this. Then, you know, like then it doesn't meet the human rights, or they have human rights to access to have access to the healthcare. And then that's the reason why that they, as Mr. Ravichandran mentioned, that what is the difference between the private and public healthcare system or healthcare institutions. I think ESIC has to compete with many private providers, particularly in the urban areas where the price might be lower, but at the same time that ESIC or PMJY has its own role to extend the coverage to those who have much more limited access to the healthcare and health service, you know, as a national system. This is how I see, you know, how I think as a this is my personal opinion, and not necessarily the ILO view either, but, you know, like this is how I see, you know, the differentiation. The principle is important to introduce, but there are certain, up to certain extent, because of the nature of the health service is not complete private, you know, private goods, or it's a public goods, you know, as I see. So, but this is just my personal opinion. So, you know, like since, you know, like there are two opinions there, so, you know, like I thought, why not to bring my opinion to this discussion? And there's no correct answer for this question anyway, because the country will develop, and then country will adapt to the right. Country needs to adapt to the right direction depending on the country's situation, country's economic development, national political situation, country's structure, which is quite specific in case of India, and number of population and the size of the country either. So thank you very much for, I'm going to close this entire session, and then I really enjoyed this moderating this session, which was a little bit challenging sometimes because everybody has a different opinion, and some questions might be a little bit difficult to answer even, and because everybody has a different ideas about how the healthcare is to be ideal for the country. Whereas that there is a fact, we need to go back to the fact that they, as Dr. Madan Gopal mentioned, that 40% of population do not have health insurance coverage. This is a fact as such of India at this moment, and then we need to tackle this problem, and then how to expand to this missing middle is. There are many ways, you know, like listed up, not only for strengthening, you know, like this public system, but also, you know, like there was a very active discussion on the private insurance system, private health insurance system, to be strengthened, you know, like to provide more opportunity for the opportunities for the private health insurers also. And which will be also taken, shall be taken into account in the process of developing the healthcare system or health insurance system in the country. But as I mentioned, that achieving universal healthcare is very challenging in many sense. It's not only about cost, but it's a system or human resource. As equality, you know, many things needs to be taken into consideration to achieve universal health care to the country. But I think this is the general direction, general direction wise, that the people has, everybody has a human rights to have a secured access to the basic health care. This is the minimum guarantee which needs to be secured, which is also mentioned in the ILO standard recommendation 202, social protection floor also. So I think, you know, like there are certain deviation of the opinions though, but the direction which we are going, I hope is kind of same. You know, we are trying to achieve to the same direction for the good for the country and for the good for the people. So thank you very much for your active participation. And then I apologize for the situation that we are not able to answer to all questions. I try to cover the questions or the comments as much as I can, but the time, there is a time limitation also. So I hope there will be some other opportunities to discuss about these subject areas in near future. Thank you very much indeed. And sayonara.
Bye.
Thank you very much for the panelists. Thank you.
Thank you.